Good morning, Orlando. We're coming to you from Boston. Good to see you here today. We're going to present a case of repeat ablation for persistent atrial fibrillation. We can go to the slides for a moment. And we'll go to the next slide, please. So just want to talk about our team here. The EP physicians with you in Orlando, Jeremy Ruskin and Moussa Mansour. Here at the table, myself, Conor Barrett next to me, and Nate Van Housen next to him. We'll pan over to anesthesia, where we have Heidi Boss and Kate Slattery. And then back to nursing, you may see behind us Chrissy Jewell, Kelly Hartnett, and our nurse manager, Sharon McKenna. And then if we pan to the back, our engineer, John Pink Chevalier, who's probably making things actually work right now, and Bill Manley, Leanne Petzik, one of our other EP physicians, in back as well. Okay, so we'll come on back this way and move to the slides. And next slide, please. So case today is a 62-year-old man with symptomatic drug-refractory AFib, initially refractory to propafenone, and then later refractory to amiodarone, persistent fib with a prior catheter ablation procedure that was done this past August. At that time, he had wide area pulmonary vein isolation that was tested with adenosine. He had initial left vein reconnection with adenosine, but at the case end, all veins remained isolated with adenosine. Also had posterior LA ablation that was not complete due to esophageal warming. He had relatively early recurrence of AFib after ablation. Amiodarone was tried, cardioversion was tried, and AFib recurred. And then he's back here for a repeat procedure. Next slide, please. So he's been off amiodarone for about a month before this ablation, also on atorvastatin, metoprolol, and rivaroxaban. And by echo, before his first ablation, he has a normal ejection fraction and biatrial enlargement. Next slide, please. So this is his first lesion set, which is a pretty typical lesion set for persistent atrial fibrillation done here. Wide area pulmonary vein isolation with posterior isolation. You'll see different colors to the dots here. This was scaled based on forced time interval, with a pink dot being at least 300 and a sort of bright red dot being at least 400 grams seconds. And you can see almost all of the lesions met the criteria of 400 grams second, except on the posterior wall, as is often the case, where proximity to the esophagus caused the lesions to have a slightly lower FTI. Next slide, please. So in anticipation for this case, we just 2 days ago did a delayed enhancement MRI scan, which shows predominantly the lesion set that was done before. You can see lesions on the left side on the AP view. You can see lesions around the right pulmonary veins, and you can see a bit of the left vein lesions. Interestingly, posteriorly, you see lesions along some regions that ablations were done, but not others. There's not much evidence here of the roof line that was done. We'll go on to the next slide, please. So here's a pretty direct comparison of the lesion set that was done 3 months ago and the delayed enhancement MRI that was done 2 days ago. And again, in many of the areas that were ablated, you can see pretty dense areas of fibrosis detected by the delayed enhancement MRI. For example, in the AP view, there's a dense line of fibrosis anterior to the RSPV that seems to trail off a little down toward the inferior veins. Posteriorly, you see relatively dense lesions on the inferior line, but the lesions are perhaps less evident heading up toward the roof. So we'll move on now to the mapping system. We note that this is a relatively new mapping system, or new iteration of the mapping system, that allows for integration of magnetic and impedance data, and so perhaps creates a slightly more accurate anatomic map. In this particular case, the patient arrived in atrial fibrillation. We did some mapping in atrial fibrillation, looking at fractionation and the like, but then we cardioverted the sinus to look for voltage and sinus rhythm and activation pattern. So this is a AP view showing the electron-anatomic map that we created on the left and the delayed enhancement MRI on the right. One of the things you'll see looking at the activation map on the left is relatively rapid sinus rhythm activation of the left atrium, except you see a region of slow activation down toward the mitral annulus anteriorly, just anterior to the appendage where the cursor is now. And that's an area that no ablation was done before. It may be obscured to your view a little bit. Maybe we'll move the catheter down slightly here, but you can see that there is an area of spontaneous fibrosis at this same region. So this patient appears to have some spontaneous fibrosis in this anterior left atrial region with delayed activation by electron-anatomic mapping. I note that this was an automated mapping setting. We mapped for about 7 minutes in sinus rhythm, obtained about 3,000 points, and about 1,400 of those are being displayed to you. We also found on this activation mapping that the left veins remained isolated, but the right veins, despite being isolated at the end of the last case with adenosine, were reconnected.
Kevin, can you please repeat what you just said? I missed what the findings were of the pulmonary veins from the prior ablation.
Yep, so the left veins remained isolated. Interestingly, those were the veins that had reconnected with adenosine and then required repeat ablation, and then remained isolated with adenosine. The right veins had remained isolated with adenosine from the start of the last case, but 3 months later had reconnected. So looking at the activation map.
So
here,
Kevin, I'm sorry. I want to ask you to repeat that. For some reason, we couldn't understand well. So which veins were isolated from the prior?
I apologize. So at the end of the last case, all veins were isolated, and all veins remained isolated with adenosine, although the left veins had initially connected with adenosine, and then after additional ablation remained isolated with adenosine. Could you understand that?
No. Wait, so sorry, one other quick question. So are you saying, Kevin, that currently the right veins are reconnected but the lefts are isolated?
That's correct.
Yes. Okay.
Maybe I was trying to say too many things. So everything was isolated at the end of the last case, but by this point, 3 months later, the right veins have reconnected and the left veins are still isolated.
Okay.
So now looking at the activation map into the right veins, you can see delayed activation into those veins. And in some cases, it may be hard to tell exactly where the line of ablation is done. We'll flip around to the posterior view now. And I think if you look here, you can see as this activation map goes, and the cursor is perhaps a line of activation into the veins right through there. And I'll admit that seeing that may be a bit with the help of hindsight, because we'll show you the lesion set we just did now. And I would say you see a lot of red.
And Kevin, so Kevin, we see that there are some recovery of probably conduction in the vein and tissue in the posterior wall, which probably led to the reconnection of the right veins. And do you think this was a function of having the esophagus there, which affected the ability of ablating more on the posterior wall previously?
I'll let Nate comment on that because he had done the prior procedure. So Nate, just make sure they can hear you and talk slowly.
Yes, I think the posterior wall reconnection, or at least there was an isolation before, I think that was all related to esophageal heating. I think when we were able to re-isolate the right superior pulmonary vein, the esophagus was not an issue this time around. So I think that was just an area that unfortunately was not fully ablated the last time, or had recovered.
And I think it's notable that the ablation lesion. I think it's notable that the ablation lesion set through that area looked very good in terms of force time integral, and also these veins had stayed isolated with adenosine, but then did reconnect. At any rate, what I wanted to point out is that white dot, which you can see posterior to the RSPV. We could probably put a cursor there. is where we re-isolated this vein today. And I think that's pretty much where this activation map does show propagation into that vein. You also see a lot of red lesions around, and I think that today we got a bit misled by the circular mapping catheter and ended up putting some lesions in places that were not effective to re-isolate this vein. And I think perhaps if we had focused on the activation map, we might have isolated it a bit faster.
I think Andrea had a question.
So I wanted to understand, so that MRI was done after the first ablation? So I don't understand, so the MRI show that looks like all the veins are reconnected, but the left were not. Is that correct?
So Kevin, the
can
question
you comment,
is,
can you comment about that?
yeah, Kevin, can you comment on the MRI findings? So the veins by electrical mapping were isolated according to what you told us, but based on the MRI, we don't see scarring on the posterior wall of the left veins.
Yep, so I think that this gets to the limitations of all of our imaging techniques. And if you look at this delayed enhancement MRI, you see nothing whatsoever on the roof, despite the fact that ablation was done on the roof, and despite the fact that we have lack of voltage on the roof. So I think that perhaps there may be some truly ablated areas that the current delayed enhancement MRI techniques are not pulling up. So I think that no technique is perfect, and you probably need to put some of these together to know what's happening. I think if you just look at the delayed enhancement MRI, you say this left superior vein almost for sure is going to be reconnected, and in fact it was not. We're going to flip around now to a...
So Kevin, go ahead, show us what you're going to do next, and if for some reason we have a problem with the audio here, so I'm sorry to ask for this, but if you can talk a little bit slower, so maybe that will help us.
So let's look a little more septally. I don't want to belabor this, but this is day of ablation of persistent AFib. So one of the things we wanted to focus on was ablation of areas of abnormal spontaneous voltage, of abnormal spontaneous fibrosis. Now, when you do a delayed enhancement MRI of someone who's already had ablation procedure, the bulk of the scar that you see is scar that you created. It can wash out some of the spontaneous scar just based on thresholding. But you do see an area here, again, we'll move the catheter down just slightly. You do see a red area on the delayed enhancement MRI image, just anterior to the appendage, and that's an area that we confirmed had low voltage, and we confirmed by this activation map you see also has delayed activation. And there are starting to be increasing data on ablation of these areas in spontaneous fibrosis to perhaps increase the success of ablation of particularly persistent AFib, but AFib in patients who develop this kind of spontaneous fibrosis.
So Kevin, just for clarification, I want to make a difference between post-ablation fibrosis that you see on the MRI scan and the spontaneous fibrosis. When you do an ablation, when you do an MRI scan after ablation and you don't have a baseline, as in this case here, we don't have a baseline late gadolinium scan, seeing spontaneous fibrosis is difficult, and that's not the aim of this MRI. So the aim of this MRI here was only to show ablation, the fibrosis that was caused by ablation.
Agreed, and perhaps we would have seen more fibrosis with an MRI before ablation, but I think that we are picking up an area with true fibrosis that was nowhere near any prior ablation lesion. And we're confirming that by voltage mapping, and we're confirming it by delayed activation of that region. So we're going to, if you look at, we'll change for just a moment to the recording system active screen projected to the audience. The yellow electrograms, you may be able to put a cursor there, are the ablation electrograms, and we've doubled the gain compared to our traditional gain up to 5,000, so it may look a little bigger than it is. But this is a low voltage area, but an area with some electrical delay, as the activation map showed, that corresponds to this area of fibrosis by MRI. And so we're going to target this region for ablation. We can now go back to the mapping system screen. And this area did show low voltage, but capture. So before we come on ablation, we'll pace at 10 milliamps at 700 milliseconds just to confirm capture here. We can go back to the recording system for a moment. And you see that we are capturing in this area. You can come off pacing. And you can see that there's some delay into this area and some fractionation even in sinus rhythm in this region. So, and this area of low voltage, delayed, fractionated electrograms in sinus rhythm extends down from here a short distance to the anterior mitral annulus. So we're planning to begin ablation here and try to ablate this particular region thoroughly until there's loss of capture at 10 milliamps. So we're gonna start ablation at this site here now.
So, Kevin, this is Vivek. I just want to understand. So, in this patient, the patient had recurrent atrial fibrillation after first procedure. You re-isolated the reconnected right veins, and then your routine strategy, or maybe this is part of a study, I don't know, but your strategy now is to basically ablate areas of low voltage, regardless of what the MRI says, right? Because you're basing this based on the Cardo mapping, right?
We're basing this on really a combination, but we recognize the limitation of the MRI in this particular case. So we're basically taking the delayed enhancement MRI and confirming that this is an area with low voltage, but with viable electrogram capture.
Yeah, I just want to clarify here. This MRI is not meant to show spontaneous fibrosis. It is for when you don't have a baseline. And when you do late gadolinium enhancement and you don't have a baseline, it's hard to see spontaneous fibrosis. So he had a couple of spots outside the areas of ablation, but because the ablation lesions shine so high and don't have a baseline, it's hard to see fibrosis outside the ablation area. So he's basing his ablations based on the electroanatomic mapping system map, voltage map.
Right. So is this a routine strategy, or is this part of a study?
It's not part of the study. That patient is not part of the study. It's an internal study, but it's not a multi-center.
I got it. So this is, the idea is to homogenize these areas. And you're doing this in paroxysmal redos or persistent redos, or
It's
both?
persistent. This patient
Only
is persistent.
persistent redos.
Correct.
And
So
what
Kevin was
voltage-
talking a little bit about strategy in persistent patients. You isolate the vein, you isolate the posterior wall, then we're going after areas of ablation of areas with fibrosis or scar, correct?
And what criteria?
I think this is something that Hans was doing and started with the BIFA ablation. Do you have any comments, Hans?
While he's coming to the mic, can you just talk about what criteria you're using to define abnormal voltage in the different segments of the atria? And is it segment specific, or do you have a general cutoff?
So in this particular case, we're using 0.5 volts as the high cutoff. And that's based on most of the literature, but there is some published literature using different cutoffs anteriorly and posteriorly. At this particular point, we're using a cutoff of 0.5. You know, in some cases, depending on how much fibrosis is or is not present, we may modify those thresholds a bit to try to pull out abnormal areas, you know, compared to the normal. But this is bipolar voltage with a cutoff of 0.5 and a cutoff for dense scar of 0.05.
Hans?
And then we confirmed delayed activation into the region, fractionated electrograms in the region, but ability to capture at 10 milliamps before the onset of ablation. In terms of strategy in this particular case, we're certainly still planning to fully isolate the posterior wall in the regions that were not isolated. but we thought that focusing on this part of the ablation in the small time window we have might be more interesting to the audience because it's a bit more new and novel than the posterior wall ablation, but that's still to come today as well for this patient. And then once we do that, we'll plan for isoproterenol at high dose, looking for triggers before we complete the procedure. And we'll certainly plan to make sure that the right pulmonary veins remain isolated with adenosine at the end of this case as well.
Hans?
And
Yes.
Yes, brief comment on the BIFA concept. We originally started doing that in paroxysmal AF cases who came back with recurrences despite durable PV isolation. And investigating the BIFA concept, we could get them to stable sinus within 90% of the cases. And then we started to do that already in the initial procedure in persistent cases. And we now went also back to the paroxysmal cases, so we now also apply the BIFA concept in paroxysmal cases in the initial ablation procedure. And what we see is that especially in female patients, despite being paroxysmal, you can get high-grade fibrosis in the left atrium, and by doing that, we could substantially improve the success rate even in our paroxysmal AF cases. So before doing that, we were stuck like with 70–80%. And with adding the BIFA concept, even in paroxysmal case, we get now to 90%, 90% plus. So we think you can apply it. Of course, everything needs to be confirmed, but we think you can apply it, or we do apply it already in first procedures in paroxysmal and persistent cases.
Can you talk about the voltage settings you use, the question that Frank asked earlier?
The voltage settings for us are, of course, there is no black and white. There is no fibrosis, no fibrosis. There are several degrees of fibrosis. We set it to red is below 0.5, then there's an intermediate zone.
I'm sorry, you said it to what?
0.5, and then there's an immediate intermediate zone above 0.5 is certainly not healthy. The intermediate zone in our lab is 0.5 to 1.5, and purple is beyond 1.5, but that does not mean that beyond 1.5 is normal. You can even have areas with 1.5 to 2 or 2.5 that are still affected.
Any, Vivek or Frank, any thoughts on voltage setup here and for endpoint and ablation in these areas? What do you think the endpoint
No, as
should
opposed
be,
to the
based on
ventricle,
all the
where it
work you
does
did?
vary apical to base and other things, but not dramatically. In the atria, the voltage in the normal heart varies a lot, so that the atrial appendage has bigger bipolar voltage than the posterior wall, and then the septums in between. So I think it may turn out that we'll need to be region-specific to describe voltage, and we may need a combination of signal characteristics to really be sure that it correlates with some fibrosis, whether it's unipolar signals or stressing the signals. I'm not quite sure we have it down to be able to define an abnormal area of voltage in the atria, unless it's dramatically abnormal. And I think it does vary depending upon the area of the atrium.
may I ask the panel a question?
Perhaps a very brief comment, because I agree perfectly on that point. And even in the FACM 3 and 4 patients, we see substantially reduced voltages even in the left atrial appendage, but still above 2 or 3, healthy and 5 or 6. So I completely agree, Frank.
So Hans, you and I had talked one time about endpoints for this. We like to pace and prove we don't have capture after we ablate these areas. And you were not doing the same. Do you?
Moussa, I'd like to do that now, if that's okay. Let's go back into Moussa.
Yeah, Kevin, go ahead.
So we'd like to demonstrate lack of pace capture where we had pace capture before. So we'll move back to sort of the middle of our ablation lesions. We had definite capture here. We're going to pace here now at 10 milliamps. And we'll go to the recording system. Maybe a little further out, because I think you're... And you can see loss of pace capture here on the recording system, please.
Thank you.
On the screen, broadcast to the center, please go to the recording system. Can you take the image that's being sent to Orlando to the recording system, not the mapping system, please?
All right, so it's good.
You can see loss of capture where we had capture before. As the catheter bounces, you may see the occasional capture beat. There's a little movement here.
Okay,
but
occasional
basically,
capture
this
beat.
area to lack of capture.
So Kevin, I think we're going to wrap up here. So I just want to summarize what you did so everyone will be like up to date. So you isolated the right veins, you isolated the posterior wall, and then you're going after areas of the areas of fibrosis that you defined by voltage mapping, and the endpoint would be loss of pace capture. So
Loss of pace capture, 10 milliamps. I want to
Yeah.
show one last thing. If we can go back to the mapping system and go to posterior view. We're about to move to the posterior wall. We won't have time to show you that. But you can see this sort of areas where this may be propagating through. Some of it may be propagating through the posterior wall where that right vein was not isolated before, so we'll probably redo this activation mapping. There's also a area of probable breakthrough from below, a little bit toward the right vein. I think you can see a little bit of that breakthrough there. And that's some of the area where we don't see so much in the way of delayed enhancement. So we're going to start focusing in that region, probably do a repeat activation map. Now the right veins are isolated. We're going to get this posterior wall isolated, and then we're going to confirm with adenosine and look for triggers.
all right, thank you, Kevin, very much, and thank you everyone on the team there.